I mean, Mr. Tester's indicated
if we take it in the spirit of what consultation means, then there should be a way of actually shaping what those local services look like. So I agree with Neil that as part of that. But in terms of the clinical redesign of services and what that actually means, where there's ability to say, well, hips and knees are going to that hospital and we're having specialised colonectomies at another hospital, whether or not there'll be the opportunity to shape that, I don't know. But in terms of the emphasis of what it will mean for local residents personally to be able to shape and input in a meaningful way, I am hopeful in the spirit of what consultation means.
Sorry, yes.
I think STPs at this stage are much more high-level strategic documents, and the principles that they want to promote are very much based on interventions and innovations that happened locally in a patchy way, but in response a lot of the time to what patients have asked, and that's why they have been successful. So it's about really bringing together these successful patchy innovations and making them the standard at a bigger scale. It's very difficult to engage when you have to write something at such high level. I think more meaningful engagement for frontline staff and also patients and the public can happen when you talk about more specific issues, and therefore there is a huge opportunity to start this now, because now we move at the implementation phase, and when we talk about engagement, perhaps we should talk more about co-design. We shouldn't see this as a one-off event. It needs to be a continuous process which is informed by data, and I think the opportunity that STPs can offer is actually by collecting data at a much bigger level, by investing in IT infrastructure, can really assist people, the public, providers, frontline professionals to make a lot more informed decisions and choices.
Can I just add to what Victoria said, because I absolutely agree that I think that's absolutely beautifully put, that meaningful engagement will come around the subsets rather than around the STPs, but I do think there's a point of principle, and it's something that Local Health Watch have said to me almost unanimously, that then does need to be a translation of the jargon-filled plans that currently exist into shorter, snappier, plain English documents, and also, very disappointingly, a fairly low proportion of STPs, probably because of the time and speed they've been working at, very few have made information available in a way that's accessible to everybody, and that needs to be rectified, because people need to be able to look back to those documents as they go through the more detailed discussions that Victoria was talking about.
As soon as you throw a three-letter acronym at the public, they switch off anyway, so perhaps we should stop calling them STPs. Jeanette, did you...
Yeah, it was to come in after, if I can call you Victoria. In that, I would challenge what you've just said, because it didn't make sense to me. You talked about it being a strategic tool, and then you talked about then there were, did you say, innovation projects that was already coming out of this strategic tool, or documents, or whatever framework. And then we heard previously that this impact will be, you talk about the public, but the public and elected responsibility lies within elected leadership in boroughs. And yet we've heard that there's a gap between those people who are held accountable to the public for many of the services that you're aiming to configure or do whatever with. And so it didn't make sense to me what you've just said.
What I said was that a lot of the time the STPs, what they have done is trying to take good examples of what has happened locally in certain areas in a very patchy way. And I know I'm biased, but I think what we have achieved in Tower Hamlets by working together with local authority on integrating the care locally is a good example that probably STPs have used across the country, and they want to replicate this example at a bigger kind of footprint. in order to develop this integrated care approach in successful local areas, we responded to what patients, the health wards, wanted us, told us that we had to address. So it was a result, the success of these local innovations was a result of responding to local need, to what people have asked us to achieve. And it could only be successful by working with the local authority and local government. Otherwise, if the point of the STPs is to work with a wide stakeholders and also the voluntary sector, not just local government and other, healthcare providers and patients.
Okay, thank you.
Thank you. Can I just ask, I mean, the remit of the London Assembly in terms of health is about addressing inequalities in health in London. So perhaps you could let me know if you've seen any evidence. Perhaps Mr. Katecha could give us whether or not you've seen any evidence of engagement with underrepresented groups such as London's deaf community, older people, homeless people, and other groups as well.
So actually that's a very good point. The equalities impact assessments, some of them have been carried out, some they're not very detailed. What I would say is there are going to be big changes potentially for groups that are vulnerable. So the way they're changing access to services, some of the move to maybe shift access to appointments to telephones or to internet services, that does affect people who may not speak English as their first language, the elderly or disabled people, or people who don't have access to the internet regularly. And obviously any changes to access to care impact them. I think one of the other areas which hasn't been looked at in a very detailed way across all STPs is female carers in particular, or female family members in particular, who often have to care for elderly or frail or family members with learning disabilities. And a lot of them haven't considered the impact on them if they say is a funding gap in social care still, or if say things don't work out as planned in STPs and you end up with people in between social care and NHS, then there's an impact on family members, and that hasn't necessarily been taken into account very clearly at the moment in these STPs.
And Mr. Tester, have you encountered any sort of good practice or bad practice of engaging with hard-to-reach groups?
So I would say in terms of the STPs, there's variation, but it's variation with a band in the middle. So we haven't seen anything absolutely atrocious and people just ignoring the issues completely, but it still feels like it's on their to-do list. Equally, we haven't seen anything that stands out as a shining star, and I think, reflecting on what Vivek's just said, one of the opportunities it's vital that STP planners do not miss is the chance to really look at population need in the level of detail that will highlight the needs and the differential needs and the different delivery and access needs of groups that often fall through the cracks in systems. And I don't think I've got confidence from what local health officials have seen in the plans so far that that's being picked up consistently. So again, that's another opportunity that good engagement will deliver, because I think we need to get a shift in culture and mindset that people stop thinking about this as another administrative chore they've got to do when they've got big plans to deliver, and seeing it as a source of insight that will help them get decisions right and help them make sure ahead of time that they don't miss out vital services. They think through things like the transport implications for different groups of people. They think about language needs and all of the other needs, and they can get some of that thinking into the planning through the engagement activity if it's done well and early.
I'm a bit worried that you can't come up with examples of good practice.
I'm worried as well.
I mean, what suggestions would you make? I mean, how should the STPs identify the requirements in their geographical area? How should they go about doing that? Briefly, if possible.
Well, so I should say, just because I haven't seen it, it doesn't mean it doesn't exist, right, obviously, because I'm looking at the national level rather than knowing all of the detail of all of the London STPs. So I'm not saying it's not there, but I haven't seen it. But how should they go about it? There is, again, a huge opportunity here to bring voluntary community sector in, social enterprise, community groups across boroughs, across the capital. That ecosystem, that infrastructure is there. I I have to say, if people don't build it into this thinking and don't ensure that the support is there for it, it won't be there forever. So there is a narrowing window of opportunity to build those mechanisms for involving all of those groups into these plans and making them permanently part of the system in a way that will benefit people but also make life easier for decision makers in the future.
Thank you. Could I just ask, is it perhaps to Dr. Siotsu Brown, whether or not you've seen engagement of frontline staff in the construction of the STPs, and whether or not that needs work, and is it important that frontline staff are involved in these plans?
Absolutely, because if STPs are going to be successful in change, is if they change behavior of professionals and patients, really. And in order to change behavior and do things differently and add value to what you offer to patients, you absolutely need to believe that it's the right thing to do, and also see it as feasible. So frontline professionals are, and especially coming from the Royal College of GPs, I think GPs are absolutely paramount to be engaged and lead the change. But also we need to think of the wider teams that we need to develop and train, and how we can develop this kind of distributed leadership across all frontline staff, and involving also the voluntary sector and patient leaders within that. So we need to work together. It's not about necessarily one group or one representative professional leading the whole thing. We need to engage and inspire all frontline staff and patients to work together on this.
Thank you. Does anybody want to add to that?
Can I just say, I mean, BMA, we did a survey, I can't remember the exact figures, Andrew probably knows, but we did a survey of GPs and of consultants across London, hospital doctors rather, across London, and I would say something, I think it's something like less than 20%, less than 1 in 5, probably even less than that, were even aware that there was such a thing going on. There is no real engagement on the front line. There is no real engagement, just to emphasise that again. All the STPs are clinically led, but the clinical leaders tend to be an individual or a couple of individuals or a small handful of clinicians who are maybe doing a few sessions a week in work, but are very heavily involved in healthcare management and are not on the ground working, which is absolutely right. You know, we can't do both things together. But there is really no clinical engagement. And in terms of, with all respect to Health Watch, I think in terms of patient involvement, that is also very poor. None of the STPs really have any patient involvement committees. Some of the Health Watches, some of the STPs have commissioned Health Watch to go out and get information, but there is no actual detailed co-production going on there.
Dr. Marlow, it says in our briefing that in November 2016, the BMA ran a survey of 615 GPs.
Yes, that's the one I was referring to.
And Consultant London. They found that 53% had not even heard of STPs,
yeah,
and 88% felt unable to influence CC decisions. Is this the survey you're referring to?
Yes, that's a survey, so thank you for the figures. It definitely is a survey, and I think that sort of feeling continues with very little engagement and very little feeling of being able to influence them. But that's because they're very, very high-level documents. I mean, if I can just quickly, because I know we're about to finish, I think from a BMA point of view, I can just really return to this. I mean, as Bill Clinton would have probably said, it's about the money, stupid. It really is about the money. I mean, if you look at, this is not my data, this is just purely taken from the STP documents. Across London, just purely the capital funds needed to implement the STPs as they stand is around £1.9 billion. That's just to implement them. That's not getting around to the health. I know we can't do, we cannot do nothing because the gap is so huge, so we have to do something. But we need to be really realistic about these figures. I mean, the STPs are basically a prospectus of false promises.
Right. Okay. So you think it is all about the money, or
I really
it's
do
not
think
all about the money?
There's a great deal of good work that the STPs have been built on, and there's lots of good ideas around it. But it's really all about the money at the moment.
Yeah. okay.
And I mean, I'm also involved, I'm a board member of a CCG, so I am aware about some of the financial pressures that we're under.
Yeah, every single government, with the exception, I think, of the Callaghan government, has actually increased expenditure on the NHS. And I'm hoping that, you know, these STPs can clear their view of just saying more money and realise that there's some structural issues there. Isn't that really what?
There are definitely some structural issues, but I think we need to be honest with the public about this.
The honesty is that we constantly shoveled money into the NHS and increased it for every government since.
We'll explore finance.
But we put in less than demand. So we put money in, but the money that we put in is about 1%, whereas demand is increasing by 3%. So we're not keeping. So you know, we have to contain demand. The STPs are a way of containing demand.
Nobody's cutting
so I would totally agree with that.
Nobody's cutting the NHS. Can we just now move on, if possible, to your idea of what role the Mayor could play in helping Londoners to engage with local STPs as well? What could the Mayor do? Who would like to, who shall I ask? Everyone. Is there something the Mayor that can do to encourage people to get involved in their STPs?
I think a debate around estates would be a way of involving people. It's very unclear exactly what's happening around estates. You know, that's to go back to the money. That's a significant part of the funding of the NHS, and I think we need clarity around what happens to estates. Does that money go back into the local community? Does it go back into the local STP? Does it go to a London-wide region? Does it go to the Treasury? And I think the Mayor could be a very powerful voice in helping us work out exactly where that goes. And if so, you close. We all agree you need to close a local hospital because it's not performing, and you could consolidate the services better. What happens to that hospital capital fund when it's sold or developed? Does it go back into the local community? Does it go back into local government? And I think that's a really, really quite important thing that the Mayor could get and would be important for.
I think if we see STPs as a plan to improve health and well-being of our population and focusing in London, I think there are a lot of actually common objectives with what the Mayor is trying to do, and I think we need to think about the wider determinants of health and well-being, so from health pollution to inequalities to mental health and healthy schools. And I think the Mayor has plans to address some of these issues, and we absolutely need to work together on these.
I think that's a really helpful frame for this, because if the Mayor simply went out and started talking about STPs, you simply repeat the problem of talking about something that turns people off because it is a three-letter acronym, as Mr. Boff said. Whereas the Mayor thinking for each of the areas that relate to health and the wider determinants of health that he has responsibility for, how is this relevant to STPs, and how do I get a debate going across London in relation to this issue? So he can do that in terms of air quality, he can do that in terms of the kind of open London agenda, the workforce issues, which are, you know, some of the massive pressures that the London STPs need to deal with. There's space for the Mayor there. I think also in terms of service reconfiguration, the fact that the Mayor controls transport and people's ability to move between services and access services is something that he can both influence and perhaps identify barriers where people might assume that transport's easier than in reality it will be. So I think building those conversations, those opportunities for people to engage through the Mayor and the Assembly's consultation mechanisms alongside health and social care's engagement and consultation mechanisms is a very practical way of taking this forward.
I mean, in our local hospital, about 20% of our non-doctor but medical workforce are European, and there's a considerable anxiety amongst those workers. So I think that's quite an important thing. I mean, just being a little bit flippant, you could license chicken shops, fried chicken shops. So, you know, obesity is a really, really big problem across London.
I think we're coming to the obligatory Brexit question later on.
All right, okay.
We will cover it.
Yeah, we will cover it. Can we just move on? If I can ask Ms. Siggins, you did allude to the fact that there was tell me if I'm wrong in misunderstanding what you said, that there was perhaps a heavy clinical lead on the development of the original STP plans. So I'm wondering whether or not you think that the requirements of social care have been adequately considered in the draft plans.
So my observations are that we had Better Care Fund previously, and then we've had the STPs. And there is very little conversation about how the Better Care Fund and the work, that means the work we're operating at a very local level with our health partners, collaboratively as local systems. There's not much talk about that at an STP level because it's something that's viewed as detailed and operational on the ground. But it's essential in actually having those local conversations about how you're actually planning and delivering services at a local level. The danger of the STP footprint is, and what next? So there's concern from politicians and from local authorities about what the next level of decision making is going to be taken up to STPs. So planning for acute care at a STP footprint, in the main, the feedback I've had, everybody's comfortable with that. But what does that mean about local democratic accountability for planning? So the STP was about health, sustainability financially, and social care resource and impact on wasn't a core part of the original STP guidance. So some areas have actually built in their social care, the impact on social care into their STPs, other areas haven't. And what I would argue is things like national living wage and the challenge to local authorities of that isn't part of STP anyway, but the shift in model of care from less hospital to more community-based care and enhanced care in the community will impact on social care. So there does have to be a local conversation. At the moment, the majority of the STPs only look at the health sustainability because that's all they were tasked with doing. So the social care conversation about the impact on social care in many areas, if it hasn't been dealt with within the local BCF plans, so if we haven't had the shift in resource there, then there is no opportunity within the STP to get it realised because it's not viewed as part of the deficit.
So what needs to change now in order for local government to achieve what the STPs set out to do?
It is about being clear about what the parameters of the STPs and how far they are actually going to meet the financial requirement of that shift in landscape. So at the moment people are still not arguing about it, but it's a known area where it's not always funded because it's not included. So you then have a separate conversation about social care. So for me, it's an open, honest debate in the STPs about the full impact financially across health and care of what it means for the health system, but also what it means for the social care system. In some of the STPs, that is covered and more at a local level, but it's not a uniform position across the board. So how are STPs fully embracing the cost impact on social care of the changing models of care and support would be the question that might be posed.
Can I just, for the sake of clarity, your criticism earlier of the sort of overt clinical lead within the starting point of the STPs, does that apply to each of the footprints in London, or is it just
there was
one or
already
two
in
of them,
many
or?
areas there has already been conversation about how we make the hospital system more sustainable and clinically how we shift care out of hospitals, enhance primary care. So those conversations were already happening in local systems. The STP didn't suddenly start that. So in local areas, you have your clinical conversations, you have your local conversations with social care, and so what does that mean for us on the ground? So that was already underway. So it's about the broader configuration of acute care and what that means, and specialities going to other hospitals where there's been high-level conversation. But the ability to then build in, well, what does that mean at a local level? At the moment in the plans, it isn't clear because they are high level. So I'd be really interested to see what the next level of detail is on the plans to say, and how is this going to be delivered at a local level?
That's quite interesting because you've actually answered the next question I was going to ask, which was really about, this idea of integration between the health service and social services, social care. I mean, it's been around for ages, and it's been we've wanted to achieve it, and for all sorts of administrative reasons, we haven't been able to. I think, to my knowledge, it's been going on since 1982 when I first became a councillor, and we've been talking about how you integrate social services in the NHS. Do you think that the STPs give an opportunity of giving us giving that a boost? That
I think enhance a little bit further, but we do need to accept that we've been working towards this now for many years. So there is already integrated health and care teams around the community, already delivering services for people. I think some of the areas of concern has always been the capacity within primary care to help support that. In many areas now you have social workers working around the patient, so you have individuals who are having very proactive and supported care at a local level with the social care input as well as the clinical input in there. So it's about just embedding that and making sure it advances to the next level. So, but it's included in the plans at a high level, but you won't see the local. What we're worried about is if more decision making, or if decision making, if these STPs become decision making bodies with delegations from CCGs, we're already seeing CCGs merge as management structures. What does that do for the planning and delivery at a local level? If our ability to plan at a local level with our local CCGs, a local authority, is taken up that one step further. Already all the money, the transformation funding goes to STP level, doesn't come down to the local CCGs anymore, albeit they are engaged. So I think there is a significant challenge.
I'd just like to follow up on that. I mean, I work in Hackney, and we have an integrated commissioning project going at the moment, and we are one of the DEVO projects. And we looked at integrated commissioning. We've actually have joint boards. We have urgent care, planned care, etc., which are being chaired by someone from the local authority and from the CCG. But we're worried that that project has actually just about hit a brick wall, because we've been recently given sort of notice that actually it's become our plans for integrated commissioning will be subsumed into the STP, and that goes on to your point about the amalgamation of CCGs. What are CCGs for? What role do they provide if they're all being amalgamated? I mean, we've already got North Central, and I think it's South West have amalgamated. And so you have someone who is chief officer of an STP, who is also chief officer of those combined CCGs. It's a very unclear position. And certainly in our particular case of Hackney, where we were well along the way of progressing integrated commissioning with a good governance structure. That's been stopped, and it's more or less stopped in its tracks, and it also calls into question how does devolution or the devolution pilots fit in with the STPs, which I'm sure you'll probably come to, and I don't know.
Thank you very much.
Can I just come and pick it up on the Better Care Fund? Earlier on this year, the National Audit Office said, and this is Sir Amos Morse, the head of the National Audit Office, said, integrating health and social care sectors is a significant challenge in normal times, let alone when both sectors are under such severe pressure. So far, benefits have fallen far short despite much effort. He then goes to say, it's important to learn from the over-optimism of such plans when implementing much larger NHS sustainability and transformation plans. He's really saying that there's no evidence to suggest that integrating social care and health care is any cheaper than giving health care than previously. So the National Audit Office is saying that whilst there are good examples of integration at local level, evaluations have been inhibited by lack of comparable data cost differences in care settings and difficulty tracking patients through different care settings. He then says, the NAO today reiterates the emphasis from the 2014 report on the Better Care Fund, that there is a need for robust evidence to show of how best to improve care and save money through integration and coordinated care. I mean, the whole emphasis of STPs is if we integrate healthcare, we will save money. Where is that evidence?
When we first entered into the Better Care Fund, there was never any evidence that integrated care would save money. And we look at the narrative behind it, it was all about improving patient outcomes.
Okay.
So somewhere along the road, this conversation about, and it saves money.
Yes. So where did that come from?
So when you actually do Better Care, sorry.
Politicians.
So So the Better Care Fund came in, but there was never, in any of the policy guidance or the policy framework, there was never the comment about it needing to save money. It was about providing seamless care for people so they have more proactive care. What there is the potential to do is actually reduce demand management. So on social care, what we do know, if people go into hospital in an unplanned way, they often come out, and if they've been having a package of care and support previously, their care needs significantly increase. So it is about the demand management element, but it was never about efficiency and saving money as a system.
Thank you.
Can I just add that when they talk a lot about this shifting care to the community, often community care is more expensive because you have higher level staff, you tend to have more one-on-one support. So compared to a hospital where you can have multiple patients per staff member, and so in a sense the costs are spread out like in economies of scale, you don't necessarily get that at community level, and that's not necessarily a bad thing, because you can get better outcomes with the patient and it's generally preferable, but it doesn't necessarily save any money. And there's a lot of mention in STPs about this, as if shifting care to community is going to save money. And I think what they're trying to say often is, if we can get people to be treated in the community, we don't have to build extra hospital beds in future for future population growth and demand needs. And so that's often where the saving is actually being made. But there's a question about if these moves to the community either don't work, or if they don't deliver the improvements in healthcare that avoid people going to hospital, given the bed shortage we already have, if we don't build those extra bed capacity because we assume these are going to work, that's where the real risk is going to come, because we're going to end up with patients trying to enter a system that can't handle that many patients. So I think that's the point, by the report by the NEO hit the nail on the head when it comes to that assumption.
Yeah, thank you. Jeanette?
Yes, Chair, thank you. I want to get some answers to some questions about prevention and this whole idea about care closer to home. Let me just read you some information that I've been provided with. I'm told that all London STPs list prevention as a priority, and here are some examples. North West London has work and health. South West London wants to work with local authorities on alcohol pricing, and both South East and North East aims to improve early years support, and North Central London will be accrediting healthy schools. Now, let me just go in about this last one I just mentioned, accrediting healthy schools. And we haven't got anyone from North Central. So I'm trying to get from you some ideas about what you understand by that. Because in my world, representing the community, 3 boroughs in North East London, the Healthy Schools programme there is, in some boroughs, absolutely very active. They've got partnerships. It's been going for, some of them have been going and having healthy school programmes for at least 8 years that I know about. In other boroughs, other parts of boroughs, less so. So what I don't understand is, and I appreciate you might not be able to tell me, but I just wanted to get some sense about what do you understand the STP in this particular locality will actually do to enhance healthy schools, improve early year support. Neil, from your Health Watch perspective.
I'm sorry, I just can't pretend to be across the detail of every STP plan in London, so it'd be wrong of me to...
It'd be wrong for you to say that. Okay, that's fine. So let's go and see Victoria, a great advocate. You think they're wonderful and will solve all our problems. Can you just tell me if you've got the insight into the next level, and just give me something concrete that I can go away and say to my constituents, you know, really, STPs are really going to be good this time round?
What I understand about healthy schools from
Let's just
a
an
clinical
example.
perspective, that we see an increasing level of diabetes and obesity in our population, and this puts huge amounts of demand and need, and we need to address this issue. And I think starting early, starting from early years, we can have a much larger effect, because we can potentially reduce the amount of obesity in children and future problems associated with obesity. But also, there is some evidence that by targeting children, you can also influence their families' kind of habits and lifestyle choices. So there is a potential by trying to educate children at schools.
Yes, and I would support you there, but why isn't this then a common goal for all of the STPs? Surely that would be appropriate for North East or South West. I mean, is it statistically based? Do you have any sort of concrete, are they based on evidence, these goals?
I suspect the set of priorities that have been set at HSTP depend on the local population needs. So perhaps, and that's an assumption, North Central, perhaps they identified that their younger population has increased levels of obesity, and that's a priority locally. I assume that this has been discussed with local public health representatives and has been identified as a need and priority in the area.
We can pick this up in the second panel.
Oh, we can pick that up in the second panel.
We can pick up the second panel, which
okay.
will have more details on this.
Yeah. Okay. If Vivek, can you tell me, let's go back to, Andrew brought it up. We know from evidence it's those people who are most disadvantaged, who are outside of, the circle of action, if you like, that really, if we're going to target and do some work in prevention, then really this would be an opportunity to do this. Do you see that, prevention, working with disadvantaged groups, marginalised communities? Has that come up in your review or your understanding of the STPs for London?
Well, I would say for London is London faces a particular issue from even just reaching these people, partly because there's a large population churn in some areas. There's people moving around a lot, and a lot of people then walk into A&E aren't registered with a local GP, for example. It's hard to reach people when they're not even registered with the local GP. Health budgets, public health budgets have been cut across quite a few councils in London over recent years. If that continues and at national level public health budgets are being cut, it makes it very hard to figure how they're going to help people reach these groups if they've got less money to do so. And some of the proposals I've seen so far in STPs, which have been detailed, seem quite optimistic. And I'm a bit skeptical about so far how good they've been at reaching these people and whether they will be able to, given the shortage of funds available, if anything, to just spend on that.
Yeah, Gary, prevention, I think the GP's role and the whole primary healthcare team is critical. I'm a former health visitor and I'm a nurse, once a nurse, always a nurse. So it concerns me when you say from your survey that local GPs were unaware when you asked them about STPs, given their role in prevention.
Just say it's not GPs across London were. I don't know about STPs are supposed to embrace local authority. I don't know what the engagement or knowledge of is across local authorities, much less GPs. But just going back to the prevention issue, even if all the prevention plans, I don't think they're plans, if the prevention aspirations, because they're aspirations, and they're often with fairly loose evidence base, if they're all achieved, they will have an achievement in maybe 10, 15 years. Then these are long-term goals. Every single STP that I've read starts off with about prevention, which is very laudable, but actually they are something for that we need to work towards for the future. So how they are able to be delivered within the STP, which as I see it is something that's looking over the next 2, 3, 4, 5 years, I think it is very, very difficult to square that. and as I say, they're purely aspirational. In terms of if we're looking at public health, I think it would be much better to have a public health across the plan across the whole of London rather than in the individual sort of five STPs. And from my point, you talked about health visitors and nurses. You know, we need to be engaging with schools really very, very strongly. My particular feeling of interest around prevention in schools is around mental health, and I think that's something that's actually very, very important. We're seeing an increased levels of anxiety and depression amongst adolescents, and that would be a very, very important aspect of prevention. But if you look at other things, I made a flippant comment about chicken shops, but actually, you know, sort of across London, we need to look, or we need to think about obesity. In North East London, we have some of the most obese children, and we have a very active public health policy to try to address that. But it's very, very difficult to implement that in the face of a sort of free market food and alcohol as well. You know, we've rejected the minimum pricing alcohol. You know, maybe the mayor needs to resurrect a London minimum alcohol price.
I mean, just staying with you, Gary, and no, I wouldn't argue against the focus we're putting on young people. But what about disadvantaged older residents of London? They don't ever seem to feature when people are talking about prevention, because it's never too late. It's never too late to bring prevention to an older person or whatever programme that
we have a project locally which is around social prescribing, which is very much focused upon older isolated people, and you know, very active involvement of the third sector, and trying to bring the social prescribing, and this is not really I suppose is a bit of preventative work involved in that. So that's very, I mean, as I said, there's lots of good stuff in the STPs. It's, you know, in the actual detail about it being locally implemented, and social prescribing would be a very powerful way of doing that.
And so let me finish with prevention. Could they not...
I'm sorry, around isolation, social prescribing around preventing isolation.
And anyone can answer this. Could they not, could an SDP not, over a 3-year period, just if you like, given the partnerships they're working in, be able to tick the boxes? Because one or other of their partners are going to be doing something towards an aspiration.
I would say that STPs do see prevention within the wider context. So health and wellbeing strategies is about supporting people in general populations to think about how they manage their health and wellbeing and their quality of life. And I think the majority of health and wellbeing strategies are being refreshed at a local level. It's important that the STPs, health leaders, continue to engage with a whole range of people within local authorities and communities about making health everybody's business, and thinking about how each of us individually engage with our own health and wellbeing, and then think about how we utilise the health service, because there are some behaviours that aren't necessarily supportive, and hence we see lots of people going to A&E and all of those sorts of things. So I think whilst you've got your key priorities in your STP, where they've tried to look at some common themed areas, so diabetes, for example, which is every area is trying to focus on reducing the increase in diabetes and how effectively it's managed at a local level. But you then need to think about how that fits in with the health and wellbeing strategy, changing population behaviours, but also many areas have got joint prevention strategies, which focuses then on specific themes of where areas are working together at a local level. In relation to your query about older people, again, this is where it won't be in the STP necessarily, but it'll be in the borough level plans that we're working together collectively as a partnership. So for my own local area, we focus very heavily on how do we engage with our community neighbourhoods to reach socially isolated older people and actually support them to engage more proactively within the community, think about their health and well-being. So there's an external reaching into the communities, but you won't see that in STP because it's too detailed. And many areas across London have the same type of approach, where supporting older people to manage their health more effectively and making them feel improved quality of life and feeling part of their community is a core part of keeping an older person healthy and active. So they'll be in the more borough level, the more focused borough level plans rather than the STP.
Okay, so so if we didn't have STPs, this work would be going on where it is, and STPs really some sort of like great big hoover that will pull up all the information of good practice that's going on in an area.
That's my view, and I know we're doing that in our area. So
Yeah.
what's worked really effectively in tackling diabetes at a local level. So I think your observation is correct. That is the intention, but recognising there's a lot more activity happening at a local level.
Okay.
I think there's a couple of things around prevention. I think one thing is that, as others have mentioned, it's a long-term strategy, and I think that one of the challenges for the STPs and the process that they went through is that there was quite a lot of focus on kind of short to medium-term sustainability, and that's maybe why prevention hasn't been as detailed in STPs as they might have been, as the focus was more focused on sustainability. But I do think that colleagues have raised important questions about what STPs should be responsible for delivering, and what is actually better delivered at more of a local level. So I don't know about the detail about London, but I know that there are some STPs that have kind of their high level aspirations, their strategic plans, and then the detail is delivered at more of a local level. Sometimes footprints are quite large, so it's difficult for them to deliver all of the detail. But I think one of the key things as well in terms of prevention STPs, as we mentioned earlier, a lot of additional funding is now coming through the STP, and so the focus on prevention and the need for kind of adequate prevention needs to be raised in STPs, so that prevention strategies are invested in the long term, and it's not just focused on short-term goals.
One of the opportunities here, I think, is that, so as Gráinne said, all this very local work will have been going on and won't be visible in the STPs, but what the STPs can and should look at is where there's an overlap between the different agendas they're looking at. So there are some issues that there's a preventative aspect, there's also an aspect in terms of cost efficiency, there's also an aspect in relation to access to services. So the best example I can think of that isn't actually a London example, it's what's happened up in West Yorkshire, where for a really long time now there's been quite poor access to NHS dentistry for a number of boring contractual reasons. They've had a real impact on people, both in terms of crisis care, but also children's oral health, and also access to oral health services for people from sort of more marginalised groups in those communities. And the STP has finally been the vehicle, because the work that a number of the local health watch done there was fed directly into the STP lead, who immediately saw the potential, and that's gone into the plan because that ticks an access box, it ticks a preventative box. So there is potential for STPs to enable people to look at some of these wicked issues slightly differently.
Okay, thank you. Let me just briefly move on to care closer to home. As Andrew mentioned, it's one of these aspirations that have been around for years, and no one would argue about that aspiration. It's about how realistic it is to achieve. Gráinne, all 5 London STPs want care to be closer to home, providing better quality care in a more comfortable setting, and preventing unnecessary and costly hospital visits. Is there not a problem if the infrastructure hasn't been set up, if there is a lack of funding to enable this transfer?
As I mentioned earlier, all areas are working towards delivering care closer to home, and the financial pressures within local authorities to deliver that within new models of care is a significant challenge. It doesn't seem to be impacting negatively yet, because local councils are going into overspend positions. We're hoping that the budget position last week will have assisted that slightly, but councils are still reporting a significant deficit in the ability to be able to do it. Hence my comment previously about the STPs and what should they include. Is it just health sustainability, or should it also include the impact on social care? And that's not for me to answer. In terms of other elements of resource, it is about having the effective, I know you've probably got a question on workforce, but it's making sure we've got the right workforce in the right places, and the challenges on local systems, especially in and outer London differences. I think that in Tower Hamlets you pay, I think, £6,000 more for a social worker. So the ability for every area to be able to have the adequately resourced staff and be able to recruit the staff, same with primary care. And also you have to have fit for purpose estate in order to actually deliver these from. So what we do know is historically there was a lot of money available for primary care investment in terms of fit for purpose primary care.
I'm very mindful of the time now, and I'm also very mindful of the fact that we have another panel waiting. So I want to skip some of the questions, okay? And you may come over to workforce, okay?
That's right, yeah. You just started talking about that, Grania. I've got two sets of questions, Chair, and I'm conscious of the time. My first set of questions is to you, Dr. Barlow, Dr. Brown, and Ms. Davenport. STPs are now moving into their delivery stage. Is the workforce, who after all are the enablers of change, at a stage where they can deliver the proposals as they stand now? If not, what changes would be required to deliver the proposals? And are these achievable within the STP timetable?
As I said, many of the STPs are predicated upon shifting care from hospital to primary care. And whether primary care teams, well, I'm pretty sure primary care teams are not ready for this. Victoria may disagree with me. Certainly, we have a workforce crisis in terms of doctors in my own, certainly in my own area. Very difficult to get new partners. It's very difficult to get locums. It's very difficult to get salary doctors. It's almost impossible to get practice nurses. Health visitors, where are they?
Gone into politics. Can I say?
So I think it is a real. It has not been. I don't think the workforce issue has been properly addressed in terms of primary care. I mean, I think that's probably my main sort of concern, really. I alluded to the fact that in terms of probably NHS providers have a different view, but in terms of NHS providers, certainly in terms of London, we have a very high percentage of European professionals working here, physiotherapists, OTs, as well as doctors, and they continue to be concerned about their status. Yeah.
I think workforce and the degree of the financial challenge are probably the two main challenges that STPs face. It's absolutely important for STPs to work with the local health education England departments and the Royal College and obviously BMA to ensure that there will be in place the extended teams that are required to deliver this shift of work from hospital to the community. We need to also think seriously about training and how do we ensure that adequate funding goes into training for all these new roles that are appearing, pharmacists, physician associates and all that, but also extra GPs, and also think a little bit more creatively about how do we use existing staff working currently within hospital environments, the acute sector, and how do we bring some of these out in the community if actually the work shifts that way.
But can these changes be achieved within the time scale? I mean, organizational changes always take time.
I think we need to be realistic. I see the STPs, I know I have been described as very optimistic before. I see the STPs as the beginning of the work that needs to be done. But we need to be realistic. We need to be honest about how quickly changes can happen. But at the same time, we shouldn't lose hope and give up.
Can I just make a quick comment? Can I just make a quick comment before we move on? Just going back to a project that I was involved in. The one thing I have to say is about moving specialists from hospitals to communities has not been shown to be a cost-effective or good use of their time.
Mr.
So we recently surveyed our members actually on what their kind of top concerns are at the moment, and workforce and finance, as others have said, are kind of top of their concerns, whether that's at kind of institutional level or STP level. I think that the STPs offer an opportunity to think about how we can use our workforce more effectively. Our members' concerns are about having the right numbers of workforce with the right skills in the right place, as others have talked about. But again, I think it will take time, and when my opening comments earlier was around being realistic about what the STPs can deliver, and I would echo what Victoria has said in that this is the start of a journey, and the STPs offer a opportunity to look at some of the workforce challenges that we have, but we definitely need to be realistic about what can be achieved in the time frame. Coming back to just about shifting care into the community, we're very clear that we need to have adequate investment into community services and ensure that those services are available before we start to shift things out. No one's ever really keen on double running because it's double the cost, but actually if we're going to do this safely and if we're going to do it effectively, then that's something that needs to happen.
In terms of the timescale,
yeah.
London has doubled the percentage of non-British staff in comparison to the national average, 22% to 10%, and with the Brexit timetable and so on. Does that cause you any concern that we
Sorry,
could be...
can you repeat that? Sorry.
The stats.
Yeah.
Well, London has doubled the percentage of non-British staff in comparison to the national average, 22% to 10%, and with the uncertainty of Brexit and the negotiations and so on, how do you see that affecting the timescale?
So, I don't know about timescales. I think NHS Providers is part of a coalition of different organisations looking at the specific workforce challenges that Brexit may pose, and as an organisation we'd be keen for our kind of EU staff that are working in the NHS see them to have the right to remain, but I wouldn't be able to comment on
Well, we are already talking about Brexit. So
okay.
my final questions to all of you, and very briefly, bearing in mind the time. We've got the STP leads following you. What do they need to do to reassure the public that the STP process and proposals won't have a negative impact on the care they receive?
Be realistic about the savings and not come out with figures, because I know I keep going back to this, but they all talk about savings and be realistic. Shifting care into community probably does have much better outcomes, but it's not necessarily a cost saving.
Bro?
I say three things: be honest, engaging, and reflective.
Spoken like a true GP.
I think from my perspective, it is about explaining things simply and being very clear about what this means for people at a local level.
Everything everyone said already, and also if that people can convince clinicians, that is who the public will listen to.
So again, I would say be realistic, implement plans at an appropriate pace for that local area, and operate within the current kind of institutional and democratic structures that allow you to have that engagement.
I'd say, just to add to the be honest point, they have to be honest about if these don't work out, their optimism and the assumptions they've made. What does that mean for the local services? Like, what is the plan B? Because a lot of them don't talk about it. But what is the contingency if things go wrong? And I think people want to know that, at least so that they're aware of what could happen.
Thank you.
Thank you. Thank you, all members of the panel. I know it's been rushed towards the end, but we do have a second panel to go to. But you've given us a lot of substance to work on, and so thank you very much. If you think that we've missed some point you wanted to make, please feel free to write to us. We're still taking evidence. You're welcome to stay for part two, but I'm going to take for a short adjournment for about 5 minutes to give us for us to restructure. But thank you very much for coming along, and thank you very much for your inputs.
Thank you.
Thank you.
GLA Chamber Sound. 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 GLA, chamber, 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 sound. GLA, chamber.
Okay, thank you very much for bearing with us, and sorry we're starting late. But can I please welcome the second panel? And Mohini, I'll ask you to, if you start introducing yourself from there.
Thank you. Thank you. So I'm Mohini Palmer, I'm a GP. I'm chair of Ealing CCG, and I'm also the North West London STP lead.
Morning, I'm David Stout. I'm the Senior Programme Director for the North Central London STP.
Good morning, my name's Steve Russell. I'm the Regional Director for NHS Improvement in London.
Good morning, my name is Jane Milligan. I'm the Chief Officer for Tower Hamlets CCG and also the North East London STP lead.
Mark Easton, Programme Director, South East London.
Thank you.
Hello, my name is Daniel Alcalese. I'm the Chief Executive of Epsom and Early Hospitals, and I'm here for South West London STP.
Great. Thank you very much for coming this morning. And you may have heard some of the discussion in part one, but I'm going to open up with a general question to all of you. Is what are the specific challenges to the London STP footprints as you see them? Mohini, can you start from you?
Thank you, Anka. The STP delivery across health and social care will be a challenge. I think the specificity and the challenges for us is the scale of change and the timelines of what we need to deliver to ensure that we have quality of care and sustainable services both from a workforce and from a financial perspective. The big challenge within the health is that we have to, for the day job, deliver safe, high-quality services while we undertake transformation for what is the right to address the needs of our population. The other challenge across is, of course, which is especially in London, is we're working across multiple organisations. As you know, in North West London, we've already been working together with CCGs for a period of time and as providers. Now we've got our local government colleagues with us working very closely, and actually we're working across multiple interfaces with the workforce, working on multiple interfaces. And therefore the change management, how we take our workforce with us, is a challenge.
Thank you. David?
Yeah, I think we all face fairly similar challenges. I suppose I'd start with the STPs are intended not just to be about money, they are also about improving quality of care and improving health outcomes, and the challenge is to do all three, not just one of those. The panel you heard earlier talked about workforce challenges. I think they're real. The challenges around how we manage, as Mahini says, how we manage the transition at the same time as keeping the show on the road. And focusing on delivery rigorously, not just thinking the STP is a plan that we write and submit somewhere, but focusing on actually delivering the change for real at local level, not simply at a STP level.
Thank you.
Very good question. So probably draw on 4 or 5 key challenges. I think the first is very common to all of the STPs, which is the changing needs of the population across London. It's very different now than it was years ago, and that's what many of the STPs are trying to address fundamentally. The second is workforce. So notwithstanding the changes that STP areas are trying to make, I think all of us would recognise that London and indeed England faces quite significant workforce challenges across all professional groups. The third is trying to achieve all of that change and deliver good services for our citizens within the resources that are available. And you heard the earlier panel touch on some of those challenges. 2 that I might just call out. One is, to build on Mahini's point, there's a lot to do in delivery of the STPs, in their ambitions. They've got positive and compelling arguments for change, but those things don't happen overnight. And they don't happen without very, very significant effort and time commitment of people who are very busy treating and looking after people who become ill across London. And then the last one is probably, I expect you'll probe us on later, is taking people with us. STP is an acronym. It doesn't mean very much to people, but STPs are made up of health and care professionals who are trying to fundamentally change the system that serves residents across London, and trying to make sure that that is owned, understood and believed in by citizens across London and elected representatives, I think, is a big challenge for us all.
Great, thank you. Jane?
So North East London, I think specifically we have got sort of clear sort of challenges in terms of our population growth, so real pockets of change in boroughs such as Newham and in Tower Hamlets, but also actually in other areas such as Havering and increasingly also across Barking and Dagenham. So I think over the next 15 years we've got a projection of about 18% increase, and that's already on a population which is quite has quite a high level of variation, so pockets of real deprivation and health inequalities, but also pockets of wealth, and to some extent a real sort of churn of people across the patch, so often not necessarily moving out of North East London, but moving between boroughs, which for a number of practices means that they have a turnover of about 40 to 50% each year. So that's a significant issue. I mean, I think the other thing is that, as I said, workforce obviously is a real challenge for us. We've got, I think Grania made the comment that we've got a sort of perhaps areas where it's easier to attract staff, so possibly in inner North East London as opposed to outer North East London. So part of our opportunities to do something about that. But actually, I think the other thing is that we have got quite a large variety of variations in care, whether that's at an acute hospital base, social care, or in primary and community care. But we've also got some fantastic examples. So it's about how, for us, about how we really draw that across and do that sharing. And as I say, I think we've had a long history of partnership working in the patch, but actually this is the first time really I think we've really tried to bring local authorities with us as well. And I'd say the other challenge I'd say for North East London is when the STPs sort of popped out of the system, we already had 3 systems already working towards transformation, and so trying to knit together the Barking, Havering and Redbridge devolution pilot, the City and Hackney devolution pilot, together with the Waltham Forest, Newham and Tower Hamlets Transforming Services Together transformation plan, as I say, is also part of the challenge but opportunity as well.
Thank you. Mark?
So if we go back to what STPs are designed to do, they came out of the plans to implement the 5-year forward view, and in particular to address 3 gaps that were identified in the 5-year forward view. So there's the health and well-being gap, so an emphasis on prevention. There's the quality gap, so addressing questions of variation. And thirdly, the financial gap. And most STPs have 3 broad strands which try and address those gaps, and South East London is no different. So we've got one strand which is improving access to primary and community care with the development of things like local care networks across South East London, expansion of access to primary care. Secondly, we've got a productivity strand, which is about getting our providers to work together in ways which are more efficient to reduce costs. And thirdly, we've got a work stream which is about secondary and tertiary care pathway redesign. And we've got 8 clinical leadership groups, as the name implies. They're led and generally run by clinicians, aiming to improve pathways of care, aiming to hit quality standards. So that's the STP in a nutshell.
Okay. Daniel?
So my answer is very similar to the rest of the panel. So South West London, we've got a growing population, it's an ageing population, there's a lot of diverse health needs. I think lots of people who live in South West London would say they don't experience the quality of healthcare both in hospitals and in the community settings that they would like to receive. There are lots of workforce and estates issues. There's clearly delivering all the healthcare that people expect within the money that we have available. And then I think we need to also acknowledge the complexity of the landscape that healthcare is provided in, and also the complexity of the conversation that we need to have with people about the future of how healthcare should be provided to enable them to live the best lives that they can.
Great. Thank you very much. I think there is consensus that we all want people to have better health care, we want to be better delivered, to be integrated, we want to do this. Let's take that for granted. There are 3 themes that came through which we need to explore. One is about finance, second is engagement, and third is the workforce, and we'll explore this in a bit more detail. I want to talk about the finances, and the STPs, when I read them, they sit on the premise that one, more healthcare can be shifted away from hospitals into the community, and that this is cheaper. And the second is that by shifting this hospital care from the hospitals into the community, we can close some hospital beds, because if you couldn't close those hospital beds, you wouldn't have the savings. So can you first of all tell me what's the evidence to say that shifting healthcare into the community is any cheaper than doing it in the hospital sector? What's the evidence on which your premise bases upon?
You want me to start?
Meaning you can start, yes?
Thank you, Anka. So I think what is important for us to deliver is that the patient, a member of the public, has the right care at the right care setting that is appropriate to their needs. That has always been the premise. That is right for the patient, right for the family, and right for the system. There is times when it is absolutely correct that the hospital is the right care setting for that patient, but there is time, for example, people and the evidence for that is there, for all the people who get dementia, who get minor illness, go to hospital. We know that day on day, after day, there is a start deterioration, and therefore the hospital is not the right care setting for that patient, and it's appropriate to provide care for them in the same quality care in an out-of-hospital setting, and that's what we are trying to do. I think the question whether it is actually cheaper is a good question, because if you're going to provide the care and give the evidence and the assurance to the public and to the workforce that is the same high quality, it may save money in certain settings, it may not save money in other settings. But it is also around the workforce and the sustainability of that. So I think it is important for us to recognize that actually it's the right care setting for the individual rather than it being hospital or out of hospital and being that binary.
Daniel, yes?
So let me give you a specific example from my hospital. So we now have a team of 60 clinicians who are made up of GPs, council social workers and reablement staff, the community nursing staff and our own staff. And the purpose of this team is to see who could we look after in their home rather than admitting them to the hospital. And if you are admitted to hospital, how can we ensure that you spend only the appropriate time in the hospital and then your care is provided in your home? This team is looking after now 20 patients a day in the community. It's all based in the hospital. The impact on those patients is very profound. So we've done lots of video blogs about what's it like for those patients to have their care at home, and they say this is so much better to have the reablement and the rehabilitation in my house rather than hospital. I'm getting better more quickly. We have looked at the cost of providing that care, and it is half the cost of someone being in a hospital bed. Perhaps the most important thing about it is that it has enabled us to have much better flow through our hospitals, so that we are delivering the A&E standard because we can admit the people who need to be admitted because we have the beds. But also we have managed to bring back all our planned care surgery that last year we couldn't fit into the hospital because it was full and was done in the private sector, and it's now all being done back in the NHS. So I think that the impact on the local NHS is huge about both improved quality for the patients, much better staff satisfaction, the people love working in the team, and also we have improved the finances. So I think it's a really good example of how everyone working together makes a big impact on improving healthcare and sorting out financial issues.
Could I just comment on your premises? Because the first premise we work on is there actually is going to be more money in the NHS in 5 years' time. So the resources available to South East London go up by something like £1 billion over the course of the next 5 years. Our problem is that if we're not careful, our costs will go up by more than the £1 billion that's available to us. So it's about how we cope with the increase in work, with the amount of extra money that's available. And our hypothesis is that expansion, the way not to deal with this is simply to continue to expand secondary care as we have been doing. Because if we do, we'll need to build another hospital in South East London, and we don't have a site to build a hospital in South East London. We don't have the workforce for another hospital in South East London. And probably more fundamentally, that would not be the right care model. Because if you look at 100 years of investigations into the London Health Service, what they all say is the London Health Service is too skewed towards secondary care and doesn't have enough primary and secondary care. Primary and community care. Primary and community care has always been relatively underdeveloped in London compared to the rest of the country. So what our proposal is, we cope with the expansion in demand by improving access to primary care and community care and associated social care. And we have lots of examples in London of how there are people currently sitting in hospital beds or sitting in A&E departments who could more effectively be treated in the community. And Daniel's given you some examples of that. The third premise we have is that actually the system can be more efficient. And there's good examples of hospitals paying different prices for basic standard stuff. That's why we think it's a good thing for hospitals in South East London to work together on things like procurement, on things like back office, doing the kind of things that councils in London have actually been doing for quite a long time. And if you do that, then STPs can make a contribution to the funding gap that we're going to have in the health service over the next 5 years.
So South East London expecting £1 billion in the NHS budget or the social services budget, or the all combined budget together?
So the amount of NHS resources available in South East London will go up by about £1 billion over the next 5 years. Health service budgets are going up in cash terms, and those bits of the NHS that rely a lot on access to specialist commissioning, as we do in South East London, actually have a bigger increase. I mean, the increase in funding in specialist commissioning is actually bigger than the increase in funding for baseline CCG funding. So there is, I think one of your members pointed out earlier, the health service budget is actually getting bigger. The problem we've got is that the rate of increase in demand will outstrip the increase in funding if we're not careful.
So there's been no cut in social services budget, 40% right across the country, none in you aren't aware of any cuts in social services?
So our STP sets out the reductions that will be that local government is facing. I mean, we all know that local government is facing funding reductions, and part of the work of the STP is to find ways of mitigating that. The bulk of the work actually takes place at borough level, because the borough relationships between CCGs and local authorities are clearly very strong. Local government doesn't particularly work on a 6-borough basis in South East London, but there's lots of work we can do together between health and social care to mitigate the impact of the cuts. There's the Better Care Fund, there's the integration both of commissioning and provision of health and social care, and clearly it's incredibly important we work together to try and address some of the issues that are coming up because of the reductions in social care funding.
Okay, thank you. Jane?
Well, I was just going to add, I suppose, we just need to be a bit clear about what we mean by shifting care into the community. And in many respects, I mean, that is where 90% of care, social health and social care happens already. And as other colleagues have said, it's about ensuring that we've got the whole system aligned to help support that. So Daniel made reference to the fact that, health care particularly and social care to some extent, but healthcare is delivered in quite a complex way. And one of the opportunities with the STP, or working in a sort of a partnership approach, is to be working much more closely with our acute colleagues in what support and the service models that do actually support primary and community care and social care to deliver that care back sort of at the ranch, because essentially when that's as Daniel says, and the same for everyone, people want to avoid hospital at all costs. So again, we've got models of where, and I talk about hospitals having sort of osmotic or leaky walls, whereby clinicians, consultants do what they are supposed to do, which is consult and reach out into supporting community teams and the locality model which sort of wraps around. So whether that's a diabetologist or a geriatrician, which is about supporting, and actually mental health is another good example, where we can actually help provide a way of managing risk, sharing expertise, and actually really supporting patients and families actually back in their communities. So I think when we talk the definition of shifting care, it's not about lifting, shifting and dropping, it's about working across the whole pathway.
Just one point I'd add, coming back to where Mahini started, we've done a bed audit across our acute and community beds, and like every other part of a health service in this country, we have hundreds of people who are in beds who don't need to be there. And not only is that bad for them, bad for the taxpayer because it's not very efficient, it's also bad for the individual who's losing independence, who's having muscle wastage, whose prospects get worse by being in the wrong place at the wrong time. So if we can plan and deliver services in a better way, we will achieve better outcomes, better quality of care.
Your assumption is those people who are in beds will be provided somewhere in the community.
Yeah, so
there's a need to put the services in this community before you can do the change.
Yeah,
so
we need to invest in the capacity to enable people to move out when they're ready to go. And there is a gap in capacity currently, so we need to invest up front, absolutely, to achieve the change.
So is there enough funding in the system to give you the opportunity of building the community services and the services in the community before you close the hospital beds down?
Yeah, we've no plans to close hospital beds down. We plan to avoid having to...
of course there are plans. I mean, we have bed closures in my part of the world.
Well, I'm not in your part of the world.
My part of the world is North West London.
In North Central London, we're planning to invest up front in increasing primary care capacity and community capacity, and that could be health or social care, to enable us to achieve what I just described.
Yes, Dr. Palmer, talked about North West London, their hospital bed closures there.
So, as you can see, when you see from the North West London STP, there is a clear shift of resource from the acute to community and mental health. There's a I can't remember the exact percentage shift. There is a complete recognition that over the last 10 years we haven't resourced primary care and community effectively. And as Mark pointed out, there is a skew towards, in London, towards the secondary care sector. And this is about resetting some of that. From a patient perspective, the care that they should receive, whether it's a primary care, community care, the hospital, should be the same, should be streamlined and should work across the system. I think it is fair to say as clinicians, you're a clinician, I'm a clinician, that it feels fairly fragmented at this point in time. And the STP allows us an opportunity to aggregate that up and to make it more streamlined. I think the investment in the community and primary care absolutely needs to happen. We've done that. As you know, in Ealing, we have actually, our integrated care service is a jointly commissioned service with Ealing Borough, where we've got social workers, intermediate care services, therapists sharing under one management team to provide a seamless service. So that is absolutely the piece of work which needs to happen. There's a complete recognition that there will be absolutely no bed closures till such time as we can demonstrate we've got the capacity, the capability, the workforce, the pathways, and the assurance to the public that it is the right to do so.
I mean, the challenge with STPs have is one is that there has to be a savings made, efficiency saving. That's one challenge the STP has. At the same time, the challenge is, of course, how do you provide the good quality care reassurance to the public? Is this quite? I mean, do you see this as a fitting a round peg in a square hole, or can this be achieved in your views?
It's a really important question, actually. How do we continue to deliver business as usual? And our business as usual is about safety and quality, about people's lives, and we have to do that all the time. So it is really interesting. I was talking to somebody, we were talking about discharge to assess and starting to think about discharging patients out. And you talk to people who mobilize this service, and they say, we have got a lot of resource in the community, a lot of resource in different organizations working differently and in different pockets and doing a lot of handoffs. This, the STP and working primary care and community work in a more integrated way allows us to minimize these handoffs and using the resources.
But does it save you money?
I think we need the plans that we're saying is actually if we do streamline some of these services, take some of the handoffs off, we may be able to drive some efficiencies within the system. But there's an absolute recognition in the GP 5-year forward view actually that we need to invest in primary care because there has been a real reduction in that over the last 8 years.
Okay, well, let me show you. Sorry. Yes,
this is it. I think it's a very good question, and it's not the case that every single part of the patient population that we treat in hospitals could be treated in the community. So it would be absolutely more expensive and probably inappropriate to treat somebody who needs intensive care in their own home. That would be much more expensive. But there are good examples where it is more cost effective in an alternative setting, because hospitals are generally the more expensive part of the health and social care system. So for patients who don't have a life-threatening illness or an immediate serious health problem, it is more cost effective for someone to be seen by their GP than in an A&E department, and that's relatively well rehearsed. So I think it's not as straightforward as A equals B, if that makes sense. You have to look at it in a slightly different way. To your question on can you do both at the same time, there are some good examples where this has happened in the past. So stroke services have been changed across England. I remember being a service manager of a stroke service in 1998, and stroke services now look very different. And in the North East, we were able to make changes to an old model of care that was a hospital bed-based model of rehabilitation after someone had had a stroke, and replace that with a community-based team, which first and foremost was what patients wanted because they preferred to be at home. Secondly, it led to better outcomes because people tended to get better faster in their own environment. And thirdly, it did save some money. It wasn't a huge cost saving, but it did make better use of the resources that we had. And all hospital systems, health and care systems will have done that and do that every year. The challenge that you're nudging at is this correct one, which is we have to do that, but STPs have to do that faster and at a bigger scale. And in some cases, it will absolutely be more cost effective to look after patients in their own homes. And in some cases, it might not be, but it will still be a better thing to do for the patient than it is to look after them in a hospital setting.
Right. I mean, the Nuffield Trust said that the government's plan to save money by shifting care into the community are built on sand. The Royal College of Physicians said that financial demands and severe pressures on the services have acted as a barrier to transformation, despite good collaboration between local authorities and the NHS organisations. It then goes on to say, this background results in a double jeopardy, not having enough staff and resources to introduce new parallel services to see if they can really work in integrating health and social care, improving patient experience, and producing efficient savings, and the danger of any potential investment being siphoned off to meet the acute crisis. So the experts are saying you need to run a parallel service, that transformation is being hampered by lack of funding and by lack of human resources in the system. And you somehow saying, I mean, you've quoted the examples of stroke care and heart centres, and I think there's evidence for that. But here we're talking about large-scale transformational service, which is under pressure of resources, it's under pressure of lack of human resources, and yet we don't, and you are being charged with saving money at the same time, how can you deliver? How can the members of the public living in London be reassured that these changes will work for them, and that the fact that they can be delivered safely?
So,
sorry, should I? It might be helpful if I give an example. So, a couple of examples. Two of the most common things that people are admitted for are diabetes and asthma. How do we reduce the number of people admitted for that? Well, one good way for asthma, there's the Mayor's strategy on cleaning up London's air. That's kind of primary prevention. That's a very good thing to do. That will, in the long term, help tackle the admissions for asthma. But actually, a lot of modern medicine is managing long-term conditions in the community and managing them well so people don't have an exacerbation of their condition and end up needing to be admitted. I've gone on visits with specialist COPD nurses who have a caseload of people at high risk of admission, and they visit people in their homes, monitor their condition very carefully, and they pick up when the patient's condition is deteriorating so that they can intervene before they need a hospital admission. And that's, that's the way medicine in the 21st century needs to be delivered, because the population is getting older, people are living with multiple long-term conditions, and we need to intervene directly earlier with the aim of preventing hospital admissions. And I think that's a good example of how you can both reduce the number of admissions and help people live better and more productive lives in the community.
But the converse evidence is that the demographics of the population are changing, the people who are being admitted to hospitals have more complex conditions, that we're not talking about asthma admissions or diabetic admissions, we're talking about complex, more patients, multiple morbidities, right? And what's clogging the hospitals up aren't asthma patients or diabetic patients.
Well, with respect, if you look at the admissions we have for those conditions, there are very, very large numbers of people being admitted for those conditions. I absolutely agree. There are people coming in with multiple morbidities, but they are the people who really need to be in hospital. It's the people we can prevent getting into hospital with, moderately simple conditions.
And that requires more investment in social services and more investment in community services. 6,000 doctors lacking in this country, and 10,000 nurses lacking and we can't even find a health visitor. How do you address those issues?
So if you take Mark's example of how can we look after people better before they come to hospital.
Pardon?
I'm just building on Mark's example of how can we look after people with chronic conditions better before they come.
Yes.
So we've had lots of conversations in our hospital with the clinicians which says, what does it look like to get it right for the patient when they come to hospital? What does a good service look like? And we ended up having a conversation with the GPs. So imagine you being a GP back in Ealing. So in the old model of
Heaven
care,
forbid.
you might refer a patient to our hospital who you've seen in practice, and then they come to A&E and they're seen by the most junior doctor in A&E. So you are a senior decision maker and you think they need to come to hospital. In the conventional system, they'd then come to hospital, be seen by a junior doctor in A&E, then a middle grade doctor in A&E, who'd say, actually, this is a medical patient, and then refer to a medical middle doctor, and finally you get to see a consultant. That is a whole heap of money to do all those consultations, but is not getting the patient the decision that they need quickly by the right person. So in our hospitals, we've just completely changed it and said, if a GP is referring someone to the hospital, the GP wants the patient to be seen by a really experienced senior doctor. So they're now all seen by consultants directly. And because the consultants are senior decision-making doctors and they know the GPs, very often what happens now is the consultant picks up the phone to the GP and says, I think we can look after your patient like this. And very often that is put more support into their homes, or let's arrange this diagnostic as an outpatient basis, or let's do it like this. And a third of the patients now don't get admitted to hospital. And you've made a much better patient experience, but you've also saved the NHS a lot of money. And if you couple that with the part of the pathway that Mark was talking about, let's make much better long-term conditions management in the community in the first place, that is how you begin to make what the STPs are talking about a real shift of let's not make everything in the hospital, let's make a whole joined-up health and care system real. And you can do it now with the resources we currently have.
Okay. So, yes.
I think just building on that, one is, of course, the rapid response at the front end of the door. The second is the flow within the hospital. So we know we've got 300 people in North West London waiting for diagnostics it's not good use of resources. And then we know we've done many day of care audits which say 30% of people could be provided care in the delayed, what we're now calling stranded patients in a different care. So that's absolutely at the end where health and social care works to take people out in the right care setting. And that impacts very quickly in mental health setting, which is completely the wrong thing for patients, for that for patients. So actually all three parts of the system coming together. And I think the STP allows that opportunity for us as providers and commissioners across a geographical footprint to say we are providing care for the needs of our population, to look at the front end, the middle and the back end. And as you know, at North West London, we're also the 7-day early adopters. We're just starting to get some data come through on that, or how even from the workforce perspective, they find it much better to come to work on a Monday morning and not feel they have to take over all the stuff that didn't happen over the weekend. And actually it's better for patients. So I think all parts of the system need to work together, including social care.
The other thing, of course, is that by shifting, the argument has been by shifting care into the community, that there's the assumption in the system that we can reduce the number of hospital beds right across the system we're talking about. That, if the argument seems to be that if you give better care in the community, we need less hospital beds, and that hospital beds can be closed. We're already working on an occupancy rate of 95% in this country, with a growing demographics, particularly in London. How do we justify that?
So I think when we look at...
Sorry, just one thing. Last week, a report was produced by Sir Brian Jarman, right, who said the hospital beds, right, and number of doctors in the system are a great determinant of mobility, right? And here we already have a hospital system which is running on this. How do we justify that argument that we can close more beds?
Absolutely, and I think there have been two other seminal reports which have come out recently. One, the King's Fund on the STP, and the Nuffield report which came out in hospital, which was actually a very good document saying actually what works in out of hospital. Then the whole issue around beds. If we work on the principle, on what every day of care audit is telling us, there are people sitting in hospital beds who could be cared for in a better care setting. Therefore, how do we improve the flow? And as Dan quite correctly said, so we can get some of our planned care stuff. Because if we are using all our beds for non-elective, actually people are not, and report for getting their elective hips done, and that's the report that's just come out yesterday from the King's Fund on that. So actually we improve that part of the system as well. And I think there is where people are waiting for diagnostics across the piece. So I think when you look at the length of stay reduction is where you could start to look at saying how you would use beds differently. And also we are, in a lot of ways, providing care differently. We've moved away from people being admitted to hospitals for 3 days to an ambulatory care setting. Every hospital is now looking at a frailty assessment, recognizing for older people, actually, we need to assess them differently in a much more different way. We've got pediatric assessment units which are again saying actually for children we can look at them and they don't necessarily need to be admitted, but actually you can treat them and send them out. So I think different models are coming up. People used to be admitted for 7 days for a cholecystectomy. They now go out in 24 hours. So we're changing the way we provide care because of technology, because of new ways of working.
I don't think any of us think the current system is perfectly efficient. I'm sure you don't think, in your clinical experience, think the current system is perfectly efficient. So there's plenty of things we can do to improve the way we deliver care. But you wouldn't start with taking beds out of the system. I don't think any of us are proposing that. We're proposing to improve the way we deliver care, monitor its impact on demand. The plans would seek to mediate the growth that will otherwise happen. So we're assuming if we did nothing, there would be 3% growth in demand on hospital activity. So the things we're seeking to do initially are avoid that happening by having better coordinated care, better invested out of hospital, mediate against growth, and then if we can get to the point where we need fewer hospital beds, well, and we can use those resources in a better way, well, that's a great thing. If we can't, then at least we've maintained current activity without having to have massive capital investment in sites we simply don't have, as we've already said.
And just to add, I suppose, part of the partnership of STP working is then about sharing where it works well. So if I think about North East London, we've got the East London Foundation Mental Health Trust, and in fact North East London Foundation Mental Health Trust, which obviously is a sort of a specific population, but their bed occupancy levels are within, under the 80%. And the reason for that is because of the whole pathway approach and the sort of, working with social care, but also with voluntary organisations, housing associations. There's a very clear place for people to move in and out of acute care when they need it, but also supported health and social care, and also into work and back to their homes. That's a really good model, and actually, in many respects, some of the sort of challenges we're trying to crack in a physical health perspective, mental health have already had a good go at it. So it's about, okay, so what do they do that we could share?
Thank you. The other thing, of course, was the upfront funding. I know that North East London asked for a £500 million funding to be upfront. Have I got the figure right, Mahini?
That's our capital ask.
For 500 million. And what we've been given, right, is 350 million for the whole of the country. How does this lack of upfront funding affect the implementation of STPs?
So I think there is, probably have to take it in three parts. So there is some stuff that we could be doing in any case. And actually we've discussed this, as you know, across North West London. We've got a joint health and social care transformation group where we've got leaders of the councils, NHS chairs, chief execs sitting together. That's kind of starting to form our governance structure and saying, actually, there are places where we would need to invest differently, and let's do it now because the evidence suggests that. We also know that actually, as part of Shaping a Healthy Future and our consultative program, that we require capital investment to make some changes at scale, and that requires investment both in the acute sector and in the community. There's almost £150 million worth of a request for investment in GP premises and in communities, in hubs, to deliver that integrated model of care, very much linked to the primary care home that's being talked about now. Actually, you're wrapping around the services around a population of maybe between 50 to 100,000. Yes, we need the capital to make that happen. But are we going to stop starting the delivery for that? No. And we've been doing that for the last 4 years in part of our Shaping Out the Future Whole Systems integration. That work and Better Care Fund, so that work continues irrespective. And yes, we do need the capital.
Okay, yes, and I will just hand you over to one of my colleagues later on. Just one more thing. In a recent speech by Simon Stevens, right, the Chief Executive of the NHS, when he was speaking to the Nuffield Trust Health Policy Summit, he says more older patients inevitably means more emergency admissions, and the pressures on A&E are being compounded by sharp rise in patients stuck in beds awaiting home care and care home places. There can no longer be an automatic assumption that it's okay to slash many thousands of extra hospital beds, unless and until there are really better alternatives in place for patients. So wherever there's proposals to slash hospital beds, is the system going to now stop right and think about, can we do this right? Because he's put a three-pronged test to be applied, right? And the Shaping Healthy Future relies upon slashing hospital beds at Charing Cross and Ealing, right? Are we going to put a stop to that?
So,
according to what Mr. Stevens said now.
I think what Mr. Stevens said is actually there should be a clear process of assurance that we have the capacity, a capability, and the workforce and the pathways before we make the changes. Absolutely right and correct. And as you know, with the maternity changes and the pediatric changes, children's services change that we have done, we've done that. We've ensured the capacity. As you know, in maternity, we have the capacity in North West London to take 36,000 deliveries. We currently want to deliver 29,000, so we've built in the capacity. Similarly, with pediatrics, we went for 127% of capacity before we made the changes on the Ealing site. So I think there is a complete recognition that we need to have that in place. And also, we have agreed across our STP that when we do the assurance, and as and when the time is right, we will work with our local government colleagues, because actually the impact that came out in the previous panel, the impact on social care in North West London, we have determined that, and that's part of our STP, that actually when you move care out of hospital, it has an impact across the entire health economy, social care economy, and that needs to be taken into account. So I think what Simon Stevens is saying is absolutely correct, and that's exactly the principles that we would be following in North West London and have done in the two changes that we've done.
Well, I don't want to be dissecting North West London here, because otherwise it's returned to the North West London meeting, but of course, let's put it on the record, right? that the STP is not signed up by London Borough of Ealing and Hampstead and Fulham, right, for obvious reasons.
Yeah.
Those two leaders have refused to sign up to the STP. So it's not, there's the amount of work in between those things isn't ideal, right? But I don't want to dissect that in detail here. But of course, as a principle, I think we want to establish, right, that we will be no hospital closures, right, unless there are provisions in the community as outlined by Mr. Stevens. Mr. Simons.
And I would say as well that though I completely recognise Ealing and Hampstead Fulham haven't signed up to the STP, but I can say for Ealing, at a local level in delivery, I work hand in glove with my local government colleagues, and we have jointly commissioned and jointly delivered services, and I don't see that changing.
Good. Okay. Andrew?
Thank you. I think the public know there needs to be transformation and would welcome any efforts to transform the NHS to meet some to be right for the 21st century, because it really isn't at the moment, and the public realise that, I think. But how would you respond, bearing in mind that the public are probably sympathetic to transformation in the NHS, to the criticisms about the lack of engagement with patients and frontline staff and wider stakeholders as well? How have you responded to that criticism, or do you think it's not deserved?
For me to start. Everyone's looking around. So I think it's a fair challenge. It's not an unfair criticism of the process that we've been through. But I think also STPs didn't just, although they arrived at a point in time, lots of health and social care systems already had arrangements in place to discuss the future of health and care services with their local populations. I would accept the point that they were sometimes variable and sometimes some were more effective than others. But the health and social care system does have a history of talking to its local communities, imperfect though it has been. I think the STP process has brought into focus the need for a more coherent and stronger dialogue with local communities. And I think all of us sat around this part of the table would probably accept the challenge that we could always have done those things better. But I'm sure the STP teams will chip in. But in many of those areas, and in fact in all of them across London, there is now positive and constructive engagement going on, using existing forums where possible, to your earlier challenge that citizens don't recognise what an STP is, to discuss what the ambitions of the STP plans are, and to get people's views on them across the 5 STPs in London. But I don't think it's an unfair challenge.
I think it might be helpful just to set out some of the things we're doing. And of course, engagement and strategic planning and transformation didn't start with the invention of STPs. Quite a lot of the STPs are actually building on a legacy of work that's happened over the last few years. In South East London, we started a programme called Our Healthier South East London in 2013, and the STP is a recognisable development of the work we started in 2013. Now, before the STP was even thought of, we'd embarked on a series of public engagement events. We have over 2,000 citizens in South East London involved in those. We've got a joint overview and scrutiny committee. We were one of the first to publish our STP last year. All of our plans, all of our delivery plans, all the background work is available on our website. We work with a patient and public involvement group. I think one of your previous witnesses said that they weren't aware of any groups of that kind. We've been running one in South East London for a couple of years. They've been involved in the design of all the clinical leadership groups. One of our most high-profile projects is on changes to orthopaedics and the possibility of centralising orthopaedic services. We've had patient representatives both on the groups that have been designing that work. We've also established things like stakeholder reference groups where we've had particular services we wanted to get public engagement on. The next phase that we're going into is what we slightly grandly called a period of civic engagement, whereby we're planning to hold a public meeting in every borough. We're taking advice from the local voluntary sector and from Health Watch on how we access hard-to-reach groups, making sure we go both through digital channels and conventional channels to make sure that we get a broader scope as possible. We work very closely with Health Watch. Health Watch have provided a critique of our STP. We've responded to that critique. We're meeting with them again on Friday to develop discussions about how the STP is evaluated. So, I mean, I think I give South East London as an example of the kind of work that probably all of my colleagues in London are doing to make sure that we get the best possible public engagement. I'm not sure we should necessarily be too worried by surveys which say that people don't recognise the STP brand. It's a kind of acronym which sounds like management speak. I suspect there's lots and lots of people who we've involved in the STP who don't realise it's the STP, including some clinicians. So when we have meetings about expanding access to primary care, it's quite possible a lot of the people in that room don't realise that's an STP initiative. They just think about, you know, extending the hours.
The problem there, as was alluded to in our first session, that if people don't get the whole connected plan, they might come to a view on one of the strategies that may be, they may change if they saw it as a part of a whole.
Yeah, and we've got to recognise there's a branding issue with STPs, because if you Google STPs, what comes up is secret plans for cuts.
Yes.
And that isn't what I think an STP is. But it's a public narrative.
Everyone should avoid TLAs. You know, they're very bad and not very transparent. If there is significant political opposition to those STPs, do you see room for the plans to be revised rather than completely abandoned, or?
Well, there's a long track record of the NHS revising its plans in the face of engagement with stakeholders. We've had some of that experience in South East London.
Yeah. Actually, the Chancellor of the Exchequer has just had an experience of that as well.
I mean, I guess the important point I'd make is the STPs, you know, they're not sort of blueprints chiselled out in stone. They're plans which will change and develop over the course of the next 5 years. A, as we engage more with sort of public and clinicians, and B, as we get experience of what works and maybe what isn't working so well. So part of the, you know, so when I'm challenged and people say, you know, can you guarantee every line of your STP will work? My response is, well, it's not, you know, 100% going to work, but over the course of the 5 years, we'll work out what isn't working so well and try and fix it.
To go to that point, we very explicitly published our plan as a draft, and we published it as a draft because A, it wasn't finished, and B, we wanted it to change. We wanted to engage with stakeholders, be they politicians, be they local people, be they our staff, to improve our plan, because our plan right now, well, in October, undoubtedly wasn't finished. So, yeah, it would be wrong to kind of, it's absolutely not chiselled in stone. It's set out there as something to work from. It's a first cut of a plan, not the final version.
Thank you very much. Thank you.
Thanks, Chair. 3 questions. And again, my first question is to all of you, and it's on the workforce. What steps need to be taken to ensure a workforce that can support the delivery of all these STPs? Dr. Perma.
So across North West London, because we've got a long history of working together, both as commission providers, we've got a workforce transformation program that's been set up, good 3-4 years ago. And we've looked at the various changes we've done. So, for example, in maternity, you know, we've recruited a whole lot of new midwives. When we did our paediatric changes, we've got 60 new paediatric nurses because we changed the way people work, and it made it attractive for people to work there. We're working on a capital nurse program. We're looking at clinical pharmacists. So across North West London, we're looking at clinical pharmacists working in primary care. So, for example, in my practice, you know, we never had a clinical pharmacist. I have now working 5 days a week, completely changed the way we work. We're looking at recruitment and retention. We're working very closely with Health Education North West London, who are pretty much part of our delivery team, to map through what the workforce is and what the gaps are and how we need to address them. I mean, that is one of the biggest challenges, is the workforce. And I think the other thing is also not just numbers. It's not about numbers, it's about the work we do and how we work differently.
Yeah, very similar. So we've got a workforce work stream, as we call it, which is linked into Health Education England. It's got social care input. It's looking both at what are the changing roles we're going to need as we change clinical models, but also how we work effectively as a whole system to attract and retain our existing staff, how we can reduce reliance on locum and interim staff so we get productivity gains without making any change to staff numbers, but have less reliance on interim staff. That it is one of the biggest enabling programs in our whole program, because we recognise it's probably the single most obvious rate limiting factor to change. If we get this wrong, then the speed at which we'll be able to implement the sorts of ambitions we have will be restricted. So, very similar story.
So one of the, you'll probably get a very similar answer from us. One of the key things that Mahili talked about was Capital Nurse, which is trying to coordinate workforce for nursing much more effectively across London, and to try and retain staff within the NHS. So we are actually quite good at recruiting in general terms. What we're less good at is retaining people. And that's for a whole combination of reasons. So most health and care systems will have quite a clear focus on how to make people's working lives better, so that there is better retention. Some of that is about working with local government and the mayor on housing, because housing is a very big barrier to workforce supply in London. And the other thing that many systems are working on is new roles. So with Health Education England, there's a very significant programme of physician associate training going on across London, and similarly nurse associate training going on across London, in an attempt to try and manage the fact that both will need new roles, but also the workforce supply of the traditional roles isn't perhaps going to keep pace with historic demand.
So again, similar. I think, as David said, same for us. Workforce, if you strip everything else away, and we had to just concentrate on one area, this would be the key thing. I think the key thing is also recognising that part of the challenge, or the part of what we need to be putting in place, is a change to how the sort of cultural aspects of workforce. So I'm a physiotherapist by trade. I've worked in multidisciplinary teams. I've managed multidisciplinary teams, and bringing people together in the same room, even in the same organisation, doesn't necessarily get what you actually need, which is about a holistic approach to managing or looking after patients and carers and their families. So there is a recognition of that organisational system development that is required. I think in North East London, given we've got a lot of building going on, we have got a real opportunity to be working with our local housing providers, and we're establishing a housing forum to do some of this, where we really need to be working with our local authority colleagues and the housing providers to look at actually supplying some really significant and actual affordable housing, because I think part of our approach is wanting to really attract people to come and work and stay in North East London, and then you need to wrap around and start to provide the career pathways to do that. GP workforce is a good example. The days of partners is pretty long gone. The shift has happened significantly in North East London, as I know as it has elsewhere. So what is the sort of, from a budding young GP coming to North East London, what's going to really keep them and actually sort of make them really light their fire? And part of that is working with our consultant colleagues in the acute hospitals to provide that sort of portfolio career. So I think so it's not just the technical numbers, it's about how we then support this, and that is, as I say, pretty critical.
I'd agree with everything that you've heard before. I think the only thing I could probably build on is the relationship with Health Education England is very, very important. I think in two respects. One is in helping their workforce planning, and they've helped us with modelling work and survey work on key skills gaps, key gaps in professions that we need to think about, either boosting the workforce training numbers or thinking about other roles that could substitute for some of that work. And that leads into the second thing they've been helping us with, sort of designing new roles and thinking, for example, of the support that nurses, doctors' assistants can give to primary care, for example, to increase capacity in primary care.
So just to echo what everyone else has said, so the STPs are describing a different way of delivering health and care. It means you need your workforce to work differently, and there are lots of examples going on about it. So in South West London, you've got people going into people's homes to provide care, and it might be a therapist and a junior doctor working together in doing things that a social care person might traditionally have done. We've got paramedics working in A&Es, and we've got new medical rotations that go between hospital and the community mental health services, so that you're training people in physical and mental health at the same time.
And again, a question to all of you. How confident are you that all these STPs can be delivered within the defined timescales? You heard some of the problems that we talked about earlier, post-Brexit and so on.
So I think like the NHS will adapt and change and will modify as things. As we go into the mobilisation and implementation, things will change. We'll have to wait and see. And I think the ambition is there, that we need to make the scale of the change. We recognise that actually from a sustainability perspective, not just money, but actually the workforce, we actually have to work differently. We are going to continue to deliver the NHS, which is our most valuable asset. Actually, we've all got to work differently.
Yeah, I'm confident we're doing the right things. I'm confident we've got leadership of the organisations working across North Central London, working together in a way that collectively they haven't before, which gives us greater optimism that we'll be able to achieve what we're seeking to do. But we shouldn't shy away from recognising the scale of what we're trying to achieve is phenomenal, and the time frame we're trying to do it in is probably more than we've achieved in the past. So could I guarantee it'll work? No. Am I sure it'll lead us to a better place than if we did nothing? Yes. And our job is to push this as far and as fast as we can and make sure we achieve what we can.
I'll repeat a little bit of what David said. So I'm confident that the STPs will deliver improvement, and they will make much faster progress towards the ambitions that are set out in them than would have been the case otherwise. And I've observed a very significant change in the 5 STPs in London over the last 5 months while I've been in this particular role. I think, though, David's right, we shouldn't underestimate the challenge that we're facing. And I suppose if you were to ask the question a slightly different way and say, well, what's the alternative? I'm not sure, and you heard that from this morning's panel as well. The stuff that's in the STPs, there is good consensus that it's the right things to do. And so if you were to ask the question a different way and say, well, how could you be more confident that they'll deliver? My answer would be, we need to now move to backing the STPs and collectively supporting them to implement some of their aspirations, rather than constantly going around can we develop the plan a bit further? And as others have said, that plan is not set in stone, it will change. You know, I'm perfectly confident that what David sets out to do in North Central London in year 2 today, in year 2 will look slightly different. And that's okay, that's absolutely fine. But if in year 2 we're still talking about the plan, then we've lost 2 years. So I suppose there's a piece about reflecting on they're not perfect, but if they didn't exist, we'd need to design something else. And there is consensus around what's in them. We need to collectively back them.
Sounds like the way Microsoft issues their new software releases. they get it out
Patch 22.
Yeah, they get it out the door first, and then they worry about whether or not it's perfect. But I get the point.
But you wouldn't want them to be building your house, would you, really?
I don't know.
Well,
People run companies.
So I suppose in terms of, I'm not sure I can talk about building a house, but anyway, I mean, I think the critical thing is about being clear of those things that can be put in place quite relatively quickly, and that might be how providers work together to deliver a more comprehensive approach to delivering trauma and orthopaedic elective care. But actually, in relation to some of the ambitions around prevention, we all know that for us, focus is around diabetes and smoking. We know that that's a long game. So we just need to be clear about what's the things that we want to sprint towards, and what are the things that we actually just want to put in place for that longer term marathon. And I think that's the way we describe it. And certainly from going back, being really clear actually almost about what the STPs are and what they aren't, and to say and about what because actually, you know, in terms of for our STP, everyone's involved in that, but it's about then what can the collective partnership do to sort of really drive through those ambitions. But as I say, being really clear about what's going to be achieved when, and as always, the ambitions are going to be in different layers.
It's always a challenge going fifth, isn't it? So I think the NHS is, yeah, could be worse. So the NHS is generally better at planning than it is at delivery. And when I speak to sort of the public in South East London, there's less of a challenge about are you doing the right thing, and it's much more of a challenge about is it really going to happen. I think Steve gave a very good response, which is the direction is right. Undoubtedly, the details of some of the things we try and implement will change as you know, as we learn and as you know, and as circumstances change. Because trying to predict what the British economy will be like, where we are with Brexit, in 2020, we're going to have to be adaptive. And in that way, it's I'm thinking about the house metaphor. If I give you the metaphor of a bridge. We're not trying to build a bridge where you would want a precise blueprint before you started laying down steel.
Even a garden
We've
bridge.
heard about the garden bridge.
This is much more of a house renovation, where you might have a nice 30 semi, and you think, well, there's some improvements we can make to it to make it more fit to my modern family.
Remind me of the garden bridge.
So I'd say the thing that gives me confidence after my 20 years so far in the NHS is the degree of collaboration that the STPs have produced. And it's collaboration between providers. So I spent all of yesterday afternoon with my colleague, District General Hospital Chief Execs in South West London, us working together on how we were going to ensure that we could provide the care collectively that people expect of us. It's collaboration between different parts of the NHS. So who would have thought a few years ago my hospital would be in 2 provider alliance with all the GPs with whom we serve? And perhaps most importantly of all, it's the collaboration between the NHS and social care. And local authorities. I have never seen it so positive. I think that will be the secret as to how actually the STPs are successful in delivery, is because of all those new collaborations.
Name me one thing that the Mayor could do to support the delivery of STPs in London.
London is one of the world's premier cities.
Yeah. No, the premier city.
The premier city. Absolutely. And actually deserves and needs to be championed the best health and social care system that there exists. And actually the Mayor could really work. I mean, he's got some great assets, in terms of TfL and NHS. We own most of the estates in London. His impact and his influence on that, his influence on transport, his influence on workforce, in how we are able to retain the workforce, because we have huge training opportunities. We don't retain people. How do we make London a more attractive place for people to work? The Mayor could really champion, and I think that the other important thing is the conversation with the public about how we all work in the NHS, we all use the NHS. Is what is our honest conversation.
So the two things.
I agree with all of that, but what else? Well, we've already talked about workforce and housing. I think the Mayor has powers and influence in terms of affordable housing that I think could be one of the parts of the solutions to our workforce challenge we talked about earlier.
I was going to use the estates example, but that's been taken. So the public health agenda, so air pollution, the point that was raised around fast food outlets, etc., that would make a very significant impact on both message and health impact and outcomes in later years.
So I think there are a lot of commonalities across all of our 5 STP plans, which, as I say, which makes sense sometimes to do once for London. So, and I think a number of those relate to some of the things that are part of the Healthy London Partnership programme anyway, but mental health, I co-chair the Mental Health Transformation Board, so I'll do a plug for that. But I think around mental health, and particularly some of the work that we need to do around stigma, which often then leads to people accessing mental health services not necessarily in the right or timely way. So I think there are some key areas: mental health, cancer, and as I say, sort of links to prevention.
10% of journeys in London are health related. So there's clearly a huge kind of co-planning agenda around health and transport. And the more we can make that transport operating on a clean air basis, the better it will be for those of us who suffer from asthma and other respiratory diseases in London.
And I would just add 2 points. So in many of the London boroughs, the NHS is by far the biggest employer. So making the boroughs really good places to work and using all your powers to help that happen is really important. And then secondly, we have a shared endeavour in London, which is how do you get the many millions of people who live in the capital to have the best lives that they can have. And that's about how do they live healthy lives. It's how do we ensure that their families work well, the education system, social care, transport, it comes together about how do we make London a great place to live. And we have a shared endeavour on that.
Thank you. Jeanette?
Yeah, can I just say, I've got a whole heap of questions about prevention and health inequalities, which we're not going to get through. So I would suggest, through you, Chair, that we send our questions out to our panel members. And I would just like to thank them for reminding us that historically London's healthcare has been skewed towards hospital, sickness, and not enough towards primary and preventative care. But so much I've heard this morning, especially from this panel, is that you've decided what's immediate, what you can get to, and there are some things that will come later. And it seems to me that, yet again, prevention is in the let's get to later. And can I just say why I say this? When we looked at the STP plans, and I'll look at you, Sir David, your plan had 2 pages about prevention compared to 18 pages of service transformation. Now, I understand you need service transformation, but prevention and health inequalities is as important at this time. From what you've said, I guess your answer is going to be, this is a draft and we'll come to prevention and health inequalities later. Is that what's going to happen?
Points. One, I'm not united me.
You heard it here first,
David Sloman, who isn't here, rather than me. But thank you very much. So our plan starts with prevention because we think it's important. And I don't judge the plan by its length of content. And I think the point made in the earlier panel, and indeed reiterated here, STPs were constructed with a 5-year time frame. A lot of primary prevention clearly operates over a considerably longer period. But remember, public health and health promotion are a local government responsibility, statutory responsibility, and they continue to be responsible for those things. So the STP is looking to say what we're going to do on top of what's already in plans, not simply replicate everything that every local authority is already doing. I'd be keen to still protect some added work on prevention in our plan. There is a financial challenge to that. We haven't yet landed the money. It is a draft, you're right. And we will, by the beginning of April, have an updated version of a plan. And if we're successful, we will have still emphasised elements of prevention, some of which do have quite quick benefit. Not all preventative interventions take years to deliver. Some are pretty quick in terms of return on investment, using an economic phrase.
And one last question about health inequalities, Chair. Can you just nod if you've completed your health inequalities impact assessment? Is that everybody nodding? Or is there somebody who hasn't done it?
You wanted to come, who was it?
Steve, you're not nodding. You haven't done
That's because I'm not an author of an STP plan.
Oh, okay.
The health equalities impact assessment will be done at any time that there is a service change that is going to be instituted. It is done with that at every event. So any change that happens, however small, will have a health equality. So the STP as a planning document is just a planning document. Just taking your previous point about prevention, So for example, in North West London, diabetes, we've isolated diabetes and alcohol as 2 big things. So we're working with our local government colleagues. We've just got a whole pile of money to roll out education for pre-diabetes. Forget the diabetes, we don't want people to get there. And that's about actually investing in pre-diabetic. The other big issue is alcohol, where actually health and social care, considering most of it is commissioned through local government, is how we work together to deal with some of the alcohol issues in North West London.
I make the point that you don't necessarily, you can say that you're going to do it next stage. What I would have a problem with is if you're not mindful of the health inequalities that is known that you're dealing with at a strategic stage, I would say to you, it is absolutely too late when you go to implementation stage to be saying to people at the implementate level, we didn't bother with this, but now you can, because isn't that a big hole in your overall strategic planning?
Sorry, I've got that. So absolutely, according to our joint strategic needs assessment in Ealing, and that's been aggregated across North West London, we have a clear idea of the demographics and what the needs of a population are, and therefore our services are commissioned to reflect that. As and when the services are commissioned, each and every service has a health equality and inequalities assessment. It is standard practice, part of our governing board standard papers, but yes, part of our GSNA, and which comes to our health and wellbeing board, absolutely reflects that.
Yeah, Daniel wanted to say something.
I just wanted to go back to prevention, to end on a positive. So let me give you an example of a fantastic healthcare prevention scheme. So there is the Nursing Home Vanguard, so it's running in Sutton. So in every nursing home, there is now a team of GPs, social care, therapists, and when needed, hospital consultants who go in and do every week and every month, depending on how frequently the patients need, a proactive assessment of their health and care needs. And that means that more of the residents of the people in the nursing and residential homes stay in the nursing and residential homes, have their care delivered in the nursing and residential home rather than coming to the hospital. They get better care. You're stopping them getting acutely unwell, and you're releasing the pressure on the hospitals. It's a brilliant scheme, and it's not only going to be rolled out right across the South West London STP. I suspect all the STPs will say this is a really good thing to do, and here is how it was piloted in this borough. Let's do it in 32 of them.
Daniel, thank you for that. I mean, I've said it on a number of occasions across this table. I want to go and live in your area. Because when you look at health indicators, when you look at everything, you guys are in a much better position to where I am in North East London. So thank you for sharing your word. But we will be writing to you about the other questions and concerns that we have about prevention and health inequalities. Thank you.
I just want to pin something down before we wind up. And I'll ask each one of you this question. Has an equality impact assessment been done for the whole plan? And you refer to bits of it, right? I'm talking about the whole plan. Has anyone done a equality impact assessment on the whole plan of the STP in the area? Mohini?
You know, for Shaping a Healthy Future, we absolutely did one as part of our consultation.
So Shaping a Healthy Future was part of the STP?
Well, in North West London, the STP, we already had...
So the question is just yes, no, has an assessment been done, impact equality assessment for the whole of the plan?
So, again, I'm going to come back and say that the acute reconfiguration plans absolutely had their equalities impact assessment done, and that was done as part of the consultation when that happened. As and when the plan is...
So for the whole STP has not had an equality impact assessment?
I'm not sure that we've had the whole plan gone through we've had an engagement, we've had
so the equality assessment has not been done for the whole plan?
No.
Okay, thank you. That's what I wanted. It's just no answer. David?
So we've done, they're high level, but we've done equalities impact assessments of every element of the plan, and then we've collated that into a overarching report, which we're looking at on Friday, funnily enough. So yes, a very initial one has been done. I think Mohini's right. As you get into finer detail,
I understand, but no one's done an impact assessment with it. You have.
So we have. Yes, we
have. You have.
Okay.
Jane?
Yes, we have.
Mark?
Yes, and it's on our website.
Yeah, it's on our website.
Danny?
So we've done one before we submitted the plan, but I'd also say to you, we've engaged with 88 different groups in South West London that cover every single protected group more than once to ensure that we have properly reflected in the plan what each of those groups thinks.
Yes. So the answer is yes for you?
Yes.
So Onkar, on that, I would say North West London has, and I think I'm describing it in a very detailed way in part of, it's also when you go to the service chain, and I think from a strategic level, the plan, yes. But as you know, the devil's in the detail. When you get the detail, that's when it really needs to happen. So, unfortunately, not to.
Okay. So, thank you. Look, I know this has gone longer than we anticipated. We could have made it gone even longer. We've cut down a lot of questions we want to ask. But look, thank you very much for your time and your effort and for your bearance with us. So can I thank you for your contributions, please? Can I ask the committee to note the report and discussions?
Noted.
Can I ask also the committee to delegate authority to me in consultation with the Deputy Chairman to agree any output of discussion from today's meeting? Can I ask the committee to note the work programme as set out in our report?
Okay.
Can I ask the members to delegate authority to me as Chair in consultation with the Deputy Chairman to agree the scope in terms of reference for the committee's next meeting on mental health issues in ex-offenders? Finally, can I ask members to agree the proposed visit on 29th of March to Springfield Hospital in Tooting to visit National Deaf Mental Health Services? The next meeting of the committee is scheduled for the 19th of April at 10 a.m. in the chamber here. Agreed? Noted? There's no urgent business, so I'll call this to an end. Thank you.
Okay, thank you.
GLA, Chamber, Sound.